Hello! So in this video, I will be discussing about contact dermatitis. Contact dermatitis is a type of eczema triggered by contact with particular substance. Eczema is a name for a group of conditions that cause skin to become dry and irritated. So the diagnostic procedure for contact dermatitis are skin testing or scratch testing, which is the introduction of allergens, and there's a prick for the outer layer and or scratching. CBC and RAS test. RAS test is used to determine if there's a presence of specific immunoglobulin E antibodies or if the person has an allergy. So the risk factors are age, occupation, history of dermatitis, and common in people with red hair and fair skin. Contact dermatitis can be irritant contact dermatitis and allergic contact dermatitis. These are the allergens, enclosed and irritant, and allergic contact here. So next is the pathophysiology of irritant contact dermatitis. So there are two, acute exposure and repeated or chronic exposure. For the acute exposure, there is direct damage to keratinocytes, causing perivascular inflammation and vascular dilation. Spongiusis, which is the accumulation of fluid in the epidermis. Vesiculation and erosion and crusting that cause shedding of crust or scaling that would lead to necrosis. When these necrotic tissues are shed, it can lead to ulceration. And the stimulation of local nociceptors can cause burning, stinging, and pruritus. And this pruritus can lead to lichenification. Lichenification is when the skin is thick and leathery. So for repeated or chronic exposure, there is damaged cell membranes, disrupt skin barrier, protein denaturation, and cellular toxicity. This could lead to this offending agent penetrating to the skin that could elicit chronic nonspecific inflammatory response that can stimulate keratinocyte proliferation. When this keratinocyte proliferate, there will be epidermal thickening, causing hyperkeratosis, which is the excessive amount formation of keratinocytes, and the rapid turnover of stratum corneum, leading to fissure and crusting, causing pain. Next is the pathophysiology of allergic contact dermatitis. The first phase is sensitization. When happens, the low molecular weight antigens penetrate the epidermis and activate Langerhans cells, which travels to regional lymph nodes and activate naive T cells. The second phase is elicitation phase. The re-exposure to offending haptens leads to type 4 hypersensitivity reaction. The sensitized T cells circulate in blood and arrive at skin site where antigen is present. This leads to the increased muscles, eosinophils, CD4+, and CD8+, T cells, and inflammatory cytokines. The mast cells release leukotrienes. Leukotrienes cause the tightening of airway muscles and the production of excessive mucus, and could lead to fever, only in severe acute contact dermatitis. The increase can cause keratinocyte apoptosis, dilation of microvasculature, and stimulation of local nociceptors. So this keratinocyte apoptosis is very essential in the It plays a critical role in regulating epidermal development and restraining carcinogenesis. That's why there is spongiusis to eliminate pre-malignant cells and resulting to papule and vesicles. So dilation of microvasculature and that leads to erythema, and stimulation of local nociceptors that cause pruritus and burning. This causes the chronic finding of leading to the chronic finding here, the scaling, lichenification, and excoriation. The excoriation, by the way, is a repeated scratching of the skin causing lesions. So the signs and symptoms are red rash, itching may be severe, dry, cracked, scaly skin, bumps and blisters, sometimes with oozing and rusting, swelling, burning, and tenderness. So for treatment modalities, we have skincare, phototherapy preparation, and proper hygiene. For medical management, the steroid creams or ointment, and oral meds like corticosteroid, antihistamine, and antibiotic. For the nursing diagnosis, impaired skin integrity related to contact with irritants and or allergens. Disturbed body image related to visible skin lesions. And risk for infection related to excoriations and breaks in skin. For the nursing interventions, encourage the patient to bathe in warm water using a mild soap, then air dry the skin and gently pat to dry. Usual application of topical steroid creams and ointment is twice a day, spread thinly and sparingly. Phototherapy preparations allow patient to verbalize feelings regarding their skin condition and encourage the patient to keep the skin clean, dry, and well lubricated to reduce skin trauma and risk for infection. So, thank you for watching. That's all for contact dermatitis. I hope you learned something.